Testing 1, 2, 3. Testing 3, 2, 1. Test 1, 2, 3. Test 3, 2, 1.
the meeting to order for our Finance and Planning Committee at 10:08 a.m. Thank you for being here, and let me see, we don't have any citizen wish to address to the committee, so we will move to item 3, approval for the minutes. Any question on the minutes? Otherwise, I'll entertain a motion.
Move approval of the minutes.
All approved? Say aye.
Aye.
Any opposed? Motion passed. Next item, I'm going to turn over to our other chair of planning, Mr. Petty.
Thank you, Mr. Chairman. Relatively short meeting today. We did have our steering committee 2 weeks ago and went well. Was it 2 weeks ago, Dorothy, or was it last week?
2 weeks ago.
Mm-hmm. Time flies when you have fun.
I mean, we've been together so much. It's like,
It was a very good meeting. We are continuing to focus on understanding the operating impact of the capital decisions, and we're pushing our consulting team to be sure that we've got that information available to us. There was a lot of discussion about medical homes and our process, and I think the meeting ended well. I think there's general agreement now that the medical home trajectory that we're on is the right one. Mm-hmm. So it was a good meeting. We'll be meeting again early next month. So I think unless you have questions, that's really all there is to report on that. Angie is here today and is going to give us our capital project update. So Angie, come on down. How are you today? Good.
Good morning. Thank you for giving me a few minutes out of y'all's packed agenda today to report on a couple of routine capital construction projects.
You have one hour limit.
I'm sorry?
You have 1 hour limit.
Oh, I could talk really slow, DT, but it would be an hour. Okay. The first one is our JPOC 1350 retaining wall repair. If y'all will recall, both JPOC buildings, the 1400 building had a brick repair, which we've already completed. If you drive by and look up, hopefully you won't even notice it because the repair is that good that you can't even see it. Looks really good. The 1350 repair that I'm reporting on today is about 90% complete. We've had a couple of rains since we've got the first retaining wall installed, and we haven't had any water intrusions, so that's good. It's doing what it's supposed to do, and we'll finish this one up. It will come off the list before I report again on the next quarter. The second one is our, can I have the next slide? I'm sorry. There we go. You'll see the retaining wall there. They will replant the grass, redo the landscape, and that'll look beautiful when it's completed here in just a couple of weeks. Next slide. This is our Hemp Hill, the corner of Hemp Hill and Allen, new parking lot. And y'all know I just like to show representation of before and after. So there's the ugly Hemp Hill building that we tore down on the left. And on the right, look at all the new parking. So that project netted us 119 new spots. The little blue thing you see there in the picture, that's if you have an emergency, you push that and we'll come and help you. That's an access controlled lot, so it's for employees with a badge. But that one is about, I put 99% complete because we have a little bit of punch out. It's not 100%, but when I come back next quarter, this will come off also, and hopefully we'll have 3 new projects on to report. Any questions? Nope. Okay, thank y'all so much.
Angie, we appreciate it. That concludes our planning agenda, Mr. Chairman.
Yes, thank you. The next item on the agenda is our September result. I think it's also our last month of FY22 also as well. Welcome, Ms. CFO.
Thank you. As DT mentioned, we have closed September. September 30th is our year end. So we are preparing next year's budget that you guys approved for 23. And we have the auditors on site. Forvis, who used to be BKD, is continuing to do our audit this year. As always, they will be presenting for your approval the audit on the December 15th board meeting. 15th, thank you. I have 15th written down, but don't know what happened there. A few other things that we're working on with the new fiscal year. I always like to try to refresh some of our board slides. I don't want to change these too often, but you may see, I'll work with DT, and you may see a few updated graphs. We've added a lot of things over the years, and they've gotten really busy. I've got some ideas, so you may see some updates to my presentation in October, for the October results, I should say. And there is a lot of work going on around the debt issuance. We continue to work with PwC. We are working with Hilltop, our financial advisor, as well as the bond legal counsels to develop the official statement that will go out and is the document that supports the people who purchase our bonds. That is slated right now, all things held constant, for February of '23. So on to September, I did add a few additional slides in here because it is our year end. And sometimes for me, it's a little hard to comprehend how we really did over the last 12 months if you don't look back at prior year. So this is the next few graphs are going to be a 4-year trend. That's important because 2019 was what we have forever tagged our pre-COVID year. So that was business as we knew it. 20 and 21 were at best unusual. And then I think 22, we're starting to find that new normal. And we've kind of carried forward the activity in 22 into our 23 budget. So this slide is really a representation of heads and beds. We have our inpatient psych. We have our inpatient med-surg beds. And then I've also got the observations that are depicted in the red line there. So of our licensed 582 beds, this is what is filling up our capacity. You will notice that we ended the year with 42,831. That's up from last year. It's slightly higher than 2 years ago, but it's not quite to the level that we were in 19. Now, these are admissions. Our length of stay has continued to rise. So when you look at our occupancy and the bed turnover, that has slowed down a little bit with increased acuity of our patients. So you may think, well, gosh, it seems like we should have more beds, but our length of stay and acuity has increased, so that turnover has slowed down. So we continue to be extremely busy. Our emergent visits I've put here, and these graphs are very similar to the ones I introduced to you during the budget. This is emergency and urgent care combined. It does include our PEC. So you can see that in the dark blue line at the bottom. 18,617 for behavioral health. That's over 50 a day. And that's a 365-day average. Our urgent care saw about 110 patients a day. And then our ED was at 294 patients a day. There are highs and lows in that. That is an overall annual average. But there's over 450 emergent cases that we see on the campus each day for 365 days last year. So very high volumes. For our clinic visits, you can see by that top line, we've just about returned to what what we were seeing in fiscal year 19, 20, and 21 were kind of riddled with us standing up telehealth, and then also some clinic closures that happened more drastically in 20. But we've got primary care at the top there. The specialty is the red line. And then at the bottom, you have those behavioral health scheduled visits. So again, more than 2,000 visits a day on average, given the 5-day work week. Our surgeries have been ramping up pretty consistently for the last 2 years. You can see that the inpatient, the red line, comprises about 38% this year of our total surgeries, and the outpatient is at 62%. Total surgeries just above 14,400. And then we kind of get into the slides that you typically see each month. We did have a little uptick in admissions, even though we're slightly behind the budget. Not necessarily a bad thing. I think when we look back at the budget, we really expected levels, those pre-COVID levels, to return. We did this budget, started the budget 18 months ago. So our admissions are right at 2,040 for the month. And I'll show you graphically what that looks like. So about the same as it was in the prior month. The one thing that looks a little odd, if you were looking at these, it's the length of stay by month. We had a pretty large uptick. And from an industry standard, this is calculated on discharged patients. And we had 2 patients that had a very high number of days that were discharged. If you remove those 2 cases, that accounts for about 0.5 of that average length of stay. So it would be much more normalized without those 2. Outpatients, again, this is for September. It does look a lot like the prior month. So we've been very consistent in the emergency department. They did have a little uptick as well as a bit lower budget this month, so that top box is green. Urgent care continues to ramp up. And then we have kind of already talked about the primary care and specialty care visits that are occurring this year. Surgeries, again, outpatient surgeries, very busy. We're seeing an uptick in inpatient surgeries, especially since the beginning of the year. And then you can see some of the surgical types below that. Those 2 graphs are year to date, not just for the month. Behavioral health, again, busy. We were kind of held constant with our patient days from the prior months. Our clinic visits were above budget, and the PEC continues to be extremely busy. Glad to see the groundbreaking that happened yesterday. So this is the actual activity that is going through that new planned facility. Our financial metrics, really, again here, we continue on the bottom left to collect some of the CHIRP money. That's the additional supplemental funding program that was approved in March. That's kind of been a slow go, but we are starting to see some of those Medicaid collections come through. Connection enrollment continues to trend upward. And then at the end of the year, this FTE per adjusted patient day at the top right continues to be favorable. We budgeted for 6.13 FTEs on average, and we finished the year at 5.75. That's a little bit lower than we closed last year. And however, the premium pay that you're going to see in a couple of pages has been unfavorable. We kind of have to we do a factor that does include some of that work. There were some year-end entries, and I want to take a moment to go through these. These are entries that we had estimated but did not have final numbers. Some of them came on July 29th. Other programs and final payments did not occur until August and September. So I'll go through these one by one, but these are really all in supplemental funding. So we picked up almost $80 million. The biggest part of that is HARP, and I'll go through that program here in a second. Up on the patient revenue line, we have filed an appeal that would, and this is kind of statewide, nationwide, for Medicare to recognize not only the traditional activity, but also the activity that's going through their managed care organizations. So that was favorable. We have, these are earlier cost reports that were favorably settled on that issue, and we were able to pick up 7.5. As the later cost reports go through final settlement, you may hear me talk about a pickup in future months. The biggest year-end entry is for HARP. HARP is a supplemental funding program that was not approved by CMS until August 31st. So HHSC had to act very quickly. We IGT'd, we drew that down, and we netted about $39 million for fiscal year 22. HARP, we expect about $35 million next year. That is not in our budget because the program had not yet been approved. So that will be helpful. Our disproportionate share, the DISH, the DISRIP, the UC, and the GME, a lot of these pickups were settled in August and September. We got our final year payment, but a lot of these pickups have to do with the public health emergency and the fact that we have gotten a concession on what we call the federal matching percentage. And we just have to push less up to get the same amount down, so we net more, and it's favorable to us. The exception to that is on DISRIP. That is the final program payment that we will receive. That program ended last year in fiscal year 21. There was the final distribution for achievement from last year, so we will not be seeing any more DISRIP dollars in the future. That program was not replaced, but 2 additional programs that were introduced when DISRIP went away was CHIRP, which we get in patient revenue, and the HARP program, which will show up in the supplemental funding revenue. CHIRP and HARP, and we have tips on a claim. So HHSC really likes the acronyms, and I'll tell you, it's a lot easier to say than the Hospital Augmented Reimbursement Program.
So Sharon, you said that $38 million was not budgeted in HARP?
It's not,
And
correct.
so and the $35 million is not in the budget either?
Correct.
For this current year, right?
For 23.
So if you were to take the supplemental funding, and this is not something to do today, but I'm curious, if we take our actual year-end 2021 financials and we remove unbudgeted supplemental revenue, I'm curious what our actual budget would have been. Because I think it would have been below.
We can take a look at that, yeah.
Because it's tough to budget when you have no idea what's coming, right?
And we got, so, you know, it goes both ways. When we requested approval and built the 22 budget, CMS was certain that CHIRP would be approved. And if you recall, we were short a pretty significant amount for the first 6 months. We typically, I would not budget for programs that are not approved, but CMS and everyone that was involved just knew that it was going to reach that point. And it hit a wrinkle, but we did finally, as a state, get that program approved. So HARP, we knew about it. We knew there was a good chance. HARP actually has 2 components. One is for the public hospitals at IGT. There's a second program proposed that's not yet approved for other private hospitals.
Oh,
So this is a very new thing for the state of Texas.
if they funded other new private hospitals, does that take away from the overall HARP availability?
No, there's 2 programs,
Okay, so
and
they're
all of it
separate.
has to do with a very complex cap room and how much charity we provide and what we can draw down in lieu of Medicaid expansion. So everything that you see under supplemental funding is Medicaid programs that would, if we had expanded Medicaid, would likely be paid through a claim process, like claim by claim. And we have all these workarounds to try to draw down those federal dollars through the waiver.
Did we have any ongoing DSRIP projects that we had to terminate because they ended the funding for DSRIP? Because I know those were projects that had been, we started receiving project proposals 7 or 8 years ago. And many of those were multi-year programs. Did we lose any programming because of DSRIP's termination?
Dr. Duncan, do you want to
Yeah, I
speak to
can
that?
speak on that. So we pretty much, those programs that we thought were impacting the outcomes of our patients, we pretty much had started to operationalize those.
Oh.
And so it was hard at one time, I think it was probably in 2018 or 19, where we would separate out what were those DSRIP FTEs versus those non-DSRIP, remember? And it became a little bit messy, a little bit complicated, and pretty much we started then working hard to begin to operationalize. And so by the time the program came down, we no longer reported those out separately.
Oh, good. Okay.
Yeah, so-
That's great. Thank you.
Ballpark figured how much of the opportunity if we opt into the Medicaid expansion program as a state?
Ooh, that's a big question. I don't recall having seen modeling of that. I think, the state of Texas does evaluate what opportunity that we would have had we been an expansion state, but I don't know that that has ever been filtered down to a facility level. I can check.
I have a slight question for you. On the average length of stay for the 2 patient outlier, is that because of acuity, or is that something that may be transition of care, or they can't be discharged because there's no place to discharge them from the family type thing? I just want to understand the reason behind
All
it.
of those had an impact from what I understand, and I don't get too much into that specific detail, but I do know that they both had a similar DRG from an infectious disease standpoint. One was a federal prisoner. So I think, again, that discharge planning would be very difficult, and one of those was a connection patient.
Thank you.
You're welcome. So from an income statement perspective, that looks really small up there, but hopefully if you want to follow along, you can, but I'm going to talk through it at a high level. On the left, the September activity does not include those year-end entries that I just mentioned in supplemental funding. There were some other entries that filter through. We hold the books open a little bit longer. We kind of get audit ready. But for the most part, what you see in September is true September activity. We had a break-even month compared to a budget of about $8 million. The largest part of that, again, impacting we were about 8.3 million short, and we were 9.9 million over in salaries. When you look at the FTEs paid, it does have a favorability, but we did, part of the budget planning and part of the budget approval discussion was just how much that premium pay continues to impact not only us, but healthcare in general. So there's just a lot of expense from a staffing standpoint. When you look at the year-to-date number, those do include the $70 million pickup. We ended the year, the hospital at $145 million compared to a $105 million budget. If you go back and look at what was projected during the budget presentation on where we would end the year, it was at $110 million. So it's a $35 million difference, and again, that was the HARP accrual. So we were pretty confident about where we would end up, and that does give me some confidence that the budget 23 is based on a good year of projection. So anyway, and again, most of the variance that's occurring, we did have some revenue pickup this year, a lot of outpatient volume as well as a favorable mix. And then we, again, year to date, the salaries were the largest negative item at contract laborers over by about 31 million, and salaries are over 48. Again, rate issues, not the hours worked and paid. For a claim, this is just a similar graph for their build encounters. Fiscal year 22, we ended up at just over 880,000 encounters. Those encounters are counted a little bit differently than the medical center would count visits and inpatients. So it's a multiple of what the medical center sees. And a claim ends the year to date is 32.3 million compared to effectively a $43 million loss, but $10.6 million ahead of their budget for 22. Again, some of those savings, they did have some revenue pickups in generation on the top side. There are open provider positions that created some salary savings on a claim. And then from an operational expense, there was some savings in purchase service. We decided to insource, for the most part, several specialties that were budgeted from an external provider, but they brought those in-house. So anyway, it netted out to be a very favorable year compared to budget for a claim. When you look at the combined, we did end up ahead of our $62.3 million budget on the far right column under the total. When you look at the combined results, our operating income was $113.3 million, so about $50 million favorable for the year. One last thing that we always do during my year-end presentation, back in 2020, and this is more of a financial statement presentation. It doesn't have any kind of an income statement impact at all, but there is an investment that's made monthly in a claim over the year. This year, it was right at $28 million. We reclassify that because we don't really expect repayment. This is an investment that we make, and it is shown in fund balance. But the board, when we approved to do this back in 2020, just wanted that heads up of what the amount was. So that is an entry that was also made at year end. Are there any questions?
I have a question. Several around the encounters for a claim.
I'm sorry.
I have some question around the encounters for a claim. It seems like we have an uptick in against budget for ortho, oncology, and surgical service and pain management. Are we seeing the effect of COVID now that they were able the escalation of disease progression here? Do we have any idea where we headed? Or it's too early? Does anybody know?
Brian, you want to come up and speak, please?
It's a good question. I think we have two big variables there that are impacting that increase. Mm-hmm. Number one, some of it is deferred care that occurred during periods of COVID. And number two, especially as you see in surgical areas, and it's why you see the uptick in some of those places, we came out of the OR closure with a physician incentive and a patient incentive to see and do more things. We had a lengthy period of time where we were doing urgent but non-elective cases, and there was some pent-up energy and demand that we had to address.
What I'm trying to look for is when it would be a right time for us to dip ourselves into more value-based care, because that may be the opportunity, because I've seen the number going down on ERI, urgent, and other area. So do we want to just try to balance that out to see when's the good time for us to start picking one of a few plan and move them to more value or high risk?
I think the market is having a greater incursion of plans, as you know.
Right.
We need to have a better understanding of the true cost per case and the cost per patient and the cost per visit to be able to manage more effectively in the efficiency piece. Mm-hmm. From a patient experience and patient outcome standpoint, we have some of the fundamentals in place to tackle that today, and we are. The biggest challenge will be moving from a quality and a distribution of a post hoc shared savings, which is how we're contracted presently, to when are we comfortable that we can take on delegated risk in the context. The push from the payers is, yes, do that today for the physicians, and I appreciate there may not be uniform comfort across hospital and physicians with that at the moment.
I'm just curious to see if we should, dip ourselves into like an MSSP or some type of ACO for the Medicare program just to get a good feel of it or something like that. But we can take it offline also as well.
Okay.
Thank you.
Thanks, Brian.
Are there any other questions on the year end? Okay.
If no question, I will entertain a motion for approval for the unaudited September financial.
Second.
All in favor? Opposed? Motion passed. Next item on the agenda. Thank you, Sharon. Is consider for professional service of broadest levels.
I'm standing in for Bill today, so
hopefully I can answer your questions.
Bill became a little bit overexcited with the events yesterday. I want that on record.
On bed rest.
In case he's listening.
Not allergic to dirt.
So as you know, Broadus and Levis is the firm that won the bid for program management services in connection with our bond work. And the original contract award contemplated that the parties would negotiate Phase 2 projects and payment. And so we have come to agreement on that. And we are asking for approval of contract award of $29,188,591, which is already included in the Facilities Master Plan program budget. That is for both the program management fees and the upper limit of sub-consultant fees that will be reimbursable in connection with those projects.
So Daphne, was there negotiating price?
So there were not, from our perspective, material changes in the text of the agreement. What we did is create some administrative simplification in terms of how they will invoice for services. And so we used our typical form of services agreement for that. And we did allow them to review the document so that we can make sure that we weren't removing any material pieces for them.
So is staff comfortable that the new agreement has struck an acceptable balance between what JPS can and should be doing with its own staff relative to program management of existing capital projects?
Correct.
Versus incorporating consulting help for those
Correct.
projects?
That was the part that was in terms of the scope for the Phase 2 projects, that was the part that was really negotiated. And none of that was pre-negotiated in the prior agreement.
Right.
Because again, that was contemplated that we would work through that. Initially, it could have been an amendment and we could have just added that to the existing agreement, but we did create a new services agreement that attached all of those projects and the dollars that would be associated with each. And Bill, I know, and Derek spent a lot of time making sure that we were focusing on compensating project manager for those things that we needed them to do and that we were appropriately pulling out things that we thought we could manage.
And what's the term of the new agreement?
Let me see if we put it here. I don't have it in front of me. So it runs through the end of the Phase 2 projects. Derek probably maybe need to help me out. I don't remember the exact term, and it looks like we didn't put it on our summary.
My point in asking is, from a performance standpoint and looking at calendar and expectations relative to Phase 2 capital expenditures, I'm curious how we categorized the term, not knowing whether or not we were going to have all the money we needed to build all of them. So part of it is to make sure, and I'm sure it's there, but we don't have the agreement, so I can't see it. So I'd love to see it. But want to be sure that, A, we've calculated enough flexibility into the term that where we have to suspend or hold on capital projects because of funding, for example, that we're not stuck.
Sure, and I can answer that. The language does give us the ability to either halt, terminate, or suspend projects. I thought you were asking me the exact, year that
not the
we
exact
said the
date,
effective
more,
date was.
more the term flexibility.
We do. We have all of that flexibility built in so that we can suspend projects as needed. And then we also have a 30-day out clause without any prior notice that's built into the agreement.
So we're not obligated under any circumstance to pay for project management for projects that we haven't authorized or that we have had to suspend because of funding.
Correct, that in anything that's not completed.
Okay.
And similarly, if we have made a payment for a project that is not completed at the term of the contract or that is not completed when we decide to terminate that contract, they would need to complete that work.
Okay. And final question, were there any personnel or subcontract changes as a result of this new agreement versus what was in the old agreement?
I think that all of the subcontractors that are still contemplated to be doing work in connection with Phase 2 are contemplated in there.
Okay.
I don't remember the exact list, like if any of them fell off, but we worked with program manager to figure out which subcontractors still have work that relate to Phase 2 projects. And then we worked with them to allocate the costs associated with each of those subcontractors.
Okay. All right, good. Thank you.
Any more questions? If not, entertain motion for approval. All in favor?
Aye.
Opposed? Motion pass. Item C, I was advised that we still have some questions, so we're going to move that into the closed session, and then we'll come back out later on.
Okay.
Item D, oh wow, the next 9 will be from Mr. McCready.
That is 1/3 of the alphabet, so if anyone's keeping track. So I'll try to go quickly.
He hasn't spent anything for calendar year 2023 yet, so this is going to be the first time.
So we're trying to set the record today. So, the first item, D, is MedStar. It is a renewal of an agreement. It is critical to transporting our non-emergent patients. Example of that would just be a skilled nursing facility transfer to that location. We really do strive to use the most affordable means of transportation, and we've actually been able to reduce this cost over the last couple of years. But still, it's an essential service. Would request your consideration on the exemption to bid as well as the agreement.
Any question for the for this? No?
Okay, move approval of the exemption to bid and for the non-emergency medical transportation agreement.
May I have second? Second. All in favor?
Aye.
Opposed? Mr. Zimmerman, do you need to abstain from that one? I noticed you abstained before, that's why.
I'm a member of.
Okay. Just want to make sure, confirm that. Go ahead. Item E.
Items E and F, I'd just like to make a couple of comments about both of those together. These are for our primary and secondary collection services, post-insurance collections as well as uninsured. We have 2 vendors that alpha split, and they work each other's primary and secondary placements. So they kind of cross each other, primary and secondary. There were 10 vendors that responded, and out of those 10 vendors, we selected item E there, which is data search, as one of those. It's a 3-year agreement with 2 option years. They are an incumbent and have done a very good job for JPS, and would request your approval for that agreement. They do a lot of third-party liability type, accidents, and they do a great job in that area.
More TPL stuff.
I move approval of item E.
I think one correction, though. E is incumbent, F is new, right?
Yes, I thought I said data search was the incumbent, but if I didn't, that is correct.
Right. So F is the replacement of FMA that was signed in August of 2014. So these are the renewal.
That's a new one. Okay.
So item F, you're correct, DT, it is a new vendor, and we were able to pick up that portion of that expense as diversity spend with Nationwide, which we did not previously have. So that's a win for us.
I did talk to Roy over the phone about item E, and we don't have any concern because their RFP come out as the one that we choose, because we were talking about the hub certification and all that stuff, so we did cover those.
So we can take item E first, Mr. Chairman?
We can do both. Can we do both at the same time? They're the same. Yeah, we'll take both.
I'll amend my motion to approve item E and F.
All in favor? Opposed? Motion passed. Item G for Network Sciences.
Yes, Network Sciences is an agreement for software. It's a software solution for screening our eligibility, patients' eligibility for not only connections but government programs, heavily embedded in what we do here at JPS with our patients. It's a 3-year term with 2 option years. There were 3 respondents to the RFP. With this agreement, we will be adding an online application functionality. We previously only had a renewal application functionality. So that is going to cost us just a little bit, but we think that's something valuable to the community and the patients to be able to apply online. And would request your approval for that agreement.
This is a good program to find source of revenue for us. So.
Think so. All right, move approval.
All in favor?
Aye.
Opposed? Motion pass. Item H, please.
So United Behavioral Health, we're all aware of our importance in the community with behavioral health. This was a planned renewal of an agreement with United Health and puts us in a position to be able to treat commercial United Healthcare members, Medicare, as well as Medicaid. And it's favorable from the prior year's contract period, so I feel like that's a good win for us and would appreciate your approval on this agreement as well.
Second.
All in favor?
Aye.
Opposed? Motion pass. Item I, please.
Item I, Mr. Chairman, is United Healthcare. This is payment for COVID vaccines. It is retroactive to 11/1 of 21, which is 12 months backwards. And that's something we've been working through with United Healthcare for quite some time to try to get that approved with them, and we've been able to do that. Would request your approval for that agreement.
Do they pay us interest for those?
Well, it's a good question, DT. We will have to go through kind of that settlement process on some of those items, such as interest, but.
Good work.
Okay, move approval.
All in favor?
Aye.
Opposed? None. Motion pass. Item K, please.
Jay?
J.
J.
Make sure I'm in the right order, DT.
J, yes.
Cigna Healthcare of Texas is an amendment to the contract where we previously were not paid for some contract services. We've been working with them for some time, and it's primarily in our outpatient clinic areas as hospital-based clinics. They were leaving some of those line items unpaid, so we were able to get them to negotiate that. We also have an adjustment for our price increase this year. Most of your managed care contracts have language that says when you do a price increase adjustment, there may be a little bit of a calibration there in the pricing. So that's taking care of both of those items.
Just my quick question. When was the last time we do any strategic pricing analysis?
We do it every year.
Every year.
There's a company that we use every year to do strategic pricing. We look at where we are in relation to the market across our peers in the Metroplex. We also look at areas where we're below, areas where we're too high, and so we do that every year as part of the budgeting process.
Any more questions? If not, entertain motion.
Second.
All in favor?
Aye.
Opposed? Item J pass. Item K, please.
Item K is the UNT North Texas Health contract related to the federal prison. Not to confuse this with the jail contract in any way. This is the 2 medical centers here, Federal Medical Center Fort Worth, which is the male prison, and then Federal Medical Center Carswell, which is the female prison. So we subcontract with UNT to provide that health care, and we get about 95% of those patients. There's about 5% that does not come to JPS. It's a very, very favorable contract for JPS, and we continue to provide that service to those patients. No, sir. Not directly, I guess would be.
But bottom line is, does this service cost us more than we collect from the federal government in terms of revenues?
No.
And from UNT?
No, I can definitely answer that with a no.
Right.
It's a good contract that would cover well more than our cost.
Okay, thank you.
Yes, sir.
Okay, motion for approval?
Second.
Second. All in favor?
Aye.
Opposed? Motion passed. The last one, item L.
Item L, Cook Children's. With this agreement, we are further aligning with Cook Children's. Previously, behavioral health care services flowed through a company called Beacon Health, and so Cook Children's is now pulling that service line into their health plan and administering claims and taking care of utilization review. And so now we're dealing directly with Cook rather than Beacon. So there's no impact on rates or term. It's just moving that service under them.
Okay, all right.
We have motion for approval? All in favor?
Aye.
Opposed? Motion passed. Item N, Dr. Elliott.
Thank you.
Thanks, Roy.
Rory.
Good morning.
The first one is to consider approval of an exemption to bid and a seventh amendment to the medical education affiliation agreement that we have for emergency medicine between Integrative Emergency Services, or IES, and Tarrant County Hospital District. The cost is there for a 4-month contract term extension that would align with the professional services agreement that is set to expire January 31st, 2023. This is already budgeted to cover the teaching and supervisory, the teaching actually and non-billable administrative functions required by the ACGME for our residency programs. And the cost is listed there at $667,524 over a 4-month period to cover the program director and faculty costs.
Any question?
Second.
I'll abstain.
Okay. Motion of, we have second already. Right?
I second it.
Okay. All in favor?
Aye.
Opposed? Motion passed. Next item.
All right, thank you. Next item is seeking approval for an exemption to bid and the Fourth Amendment to the North Texas Regional IRB Authorization Agreement between UNT Health Science Center and Tarrant County Hospital District. This is also budgeted already. It's at $235,192 annually in our approved budget. This is a continuation of our agreement from 2017 to maintain our Institutional Review Board agreement in collaboration with the North Texas IRB.
Since this is amendment number 4, when was the first time we signed with this?
2017.
17. So it's every year?
We had a couple 1 year in there as we were looking to negotiate some terms and agreements that were approved here at the board, and now we're in a good place. We wanted to extend this to 3 years.
Oh, I see. How are we doing with the regional IRB?
We're doing well. I've actually presented some of that data to the Medical Horizon Committee. I'll give another update in our November meeting, and we're doing quite well. Actually, cost savings even from our original contract and our original cost for an IRB, and we actually have about 250 studies right now. So we're actually growing significantly, doing well.
My motion for approval, please.
Second.
All in favor?
Aye.
Opposed? Motion passed.
Thank you.
Thank you. And Miss Joy Parker. Good morning.
Good morning.
How are you?
Very good, very good. All right, thank you. I am here to bring forward for your consideration consider approval of the Fifth Amendment to the Professional Services Agreement between the Hospital District and Assured Imaging. They provide our mobile mammography services for the district for our patients. This amendment would allow us an extension of the current agreement so that we can work through the RFQ process as it's time for us to evaluate opportunities for vendors to provide this ongoing service. The cost for this extension is included in our operational budget to continue this service forward.
I have a quick question for you. Since this is a mobile service, when you do the RFP, are we looking at more permanent, or are we still looking for mobile services?
For now, we're looking at mobile services. But as we are assessing our master facility plan and in the future, we are definitely looking at the evaluation of a screening service coming back in-house. As you know, we provide diagnostic services currently, and the screening is mobile, purely mobile at this time. I will say from an industry perspective and what we've seen as a value add to the community, the mobile units being out at our medical homes have provided benefit, such as when you think about our True Worth location, people with transportation issues and barriers, it's definitely afforded us to be able to be out at all of our medical homes at a variety of different times and services. So I think potentially in the future, as we look at screening services, it would be a permanent but also hybrid potential with a mobile solution as well.
Oh, I see. More expansion down the road. Any other questions, since I don't know what I was asking anyway?
Answer.
Okay. All right. Move approval.
He doesn't know what he's asking.
I'm moving approval of the amendment.
For this particular service. All in favor?
Aye.
Any opposed? Motion passed. Thank you, Joy.
Thank you.
The Adam Lane.
Good morning, great day.
Yes.
Great day with weather also as well.
So I have two items for you today. The first item is a renewal of our TSP North lease with Greg Enterprises. TSP North has 36 inpatient behavioral health beds. You may recall that previously we sublet from Haven. Haven has removed themselves from the ownership component of this, so we're now directly leasing through the owner themselves, Greg Enterprises. It is for 8 years. We did ask for 8 years with an eye towards the facility master plan program. Greg Enterprises was gracious enough to continue the terms as they existed currently. And in fact, since we asked for a longer term, they took the unamortized lease tenant improvement portion and stretched out over 8 years without any increases of fees on that. So in fact, we will be paying less operationally starting this year. And of course, the bumps just on the rent alone, not the unamortized portion of the lease. They did not. They carried it forward for the first year.
Negotiating, Ed.
Thank you, sir.
Any other questions? Otherwise, entertain motion for approval.
Move approval.
Second.
All in favor?
Aye.
Motion passed. Next item, Mr. Lane again.
The next item is an agreement between Agility Health and Tarrant County Hospital System for $9 million a year, $45 million total. This agreement really represents a watershed moment for JPS in that it is a change on how we are going to manage our mobile medical equipment and fixed equipment. It is for all of the asset management services only, capital management, equipment standardization. We did go out for RFP for this. There were 4 respondents. This was best value. What this does represent is assignment of all of our service contracts with the GE, Philips, Siemens, et cetera, to Agility, not legal assignment, but actual financial and management assignment. This represents an immediate savings of $1.8 million off our FY23 operating budget, with an additional $1.1 million coming over the term of this contract by waterfalling contracts. It also represents 24/7, true 24/7 service. Some of you may know that when Siemens says they'll be here in 24 hours, they are not, especially on a weekend. It could be up to 72 hours. This converts our staff to true 24/7 service. It also provides HIPAA data management, technical support training, bed management, a true RTLS system for actual tracking, and they have already performed our asset inventory. They already have that in their database, as well as our contract inventory. This is very significant for our system moving forward.
It is transferring the management or transferring the asset to them?
What's that?
Transferring the management of the asset? Or
just the management. The assets are ours.
So we still able to keep track of depreciation and all that stuff? Or they doing that?
Of course.
Probably a little bit better since it's all in a system.
In the system?
Yeah.
Does this include
providing for you a capital maintenance schedule on those assets so that we know when depreciation occurs, we know when replacement needs to happen, and we know when it's time to get rid of it, because it's costing us more than it is to keep it than it is to get rid of it?
Yes, sir. So they're providing two directors. One is operational, one is capital. That person actually will run the new medical equipment acquisition standards committee. Also aligns with the facility master plan for acquisition of all our equipment. They will be doing all the life cycle analysis. They've already started doing that. We brought them in temporarily on a statement of work at the beginning of the summer to phase out our previous leadership because of the number of issues that were ongoing. They're already recognizing savings for us and already starting to waterfall equipment for us.
This
Well,
was a
it's been
big
about
risk.
14 years we've been waiting on that.
I was just getting ready to say, this was,
What's that?
I mean, this was a huge risk that Adam picked up when he came, and both from a regulatory and just what you're talking about. And Adam, how long have you been here now?
2.5 years, and I
It's
picked it
taken
up
us
this summer.
2.5 years to get to this point. So Adam, you can keep your job. This is an amazing day.
There are a lot of people that deserve credit for this. A whole host of folks who've been managing the negotiations. This is not a
And just
one-person deal.
inventory, knowing to your
Yeah.
point when PMs are due and keeping it, that equipment that touches the patient safe. I mean, so.
They will,
So,
yeah.
Thanks
They will also be taken care of when something is coming in. They will verify all of that. Yeah, that's a big deal. Yeah.
So it's formulary, it's everything across the board.
Great.
Asset management, training, all of it.
That's a great job, Adam.
Okay.
Great job.
Move approval.
We'll defer to look at it next month. No, I'm just kidding. Motion for approval. All in favor?
Aye.
Opposed? Motion passed. Thanks, Adam.
Thank you. Good job.
The team.
Good job, Adam.
We are going to move into our closed session. Want to take a break for 5 minutes? we're going to resume our normal committee meeting, and at 11:24, and we have one item for approval. Item 6C, second. Any, all in favor?
Aye.
Any opposed? One abstain, right? Should we?
And he's not on the committee.
He's not on the committee, okay. All right, at this point, we don't have any other items on the agenda, so the meeting is adjourned. All right. Thank you, everybody.